on using data to build healthy communities in New Jersey. I'm Nicole Bronson. I'm a Senior Communications Officer here at the Robert Wood Johnson Foundation. As many of you know, this is the third in a series of webinars that we're doing in partnership with New Jersey Health Initiatives to help partners like you and grantees in our home state connect, collaborate, and share emerging ideas and best practices. Our first webinar explored the role of law enforcement in building healthy communities, and the second one focused on healthy housing. We hope that you'll find today's webinar, which is on data, informative, engaging, and inspiring as we reflect on the role that data plays in achieving a culture of health in New Jersey. With that, I'd like to turn it over to my colleague, Andrea Ducas, who will be moderating this discussion today. Andrea has been a Senior Program Officer with the Foundation since 2012. She's especially involved with programs related to payment and delivery system reform, purchaser and consumer engagement, healthcare price transparency, and projects that support data-driven health improvements. Thanks, everybody. Andrea?
Hi, thanks so much, Nicole. I'm really excited to be with you all today for today's webinar. And before we begin, I'd like to just go through a few housekeeping items, standard webinar housekeeping procedure. After our discussion, we're going to be taking questions from the audience. Everybody is muted, and so what we're going to ask you to do is type in your questions in the question box at the bottom left of your screen. You'll see a control panel there. Questions are only going to be able to be seen by me and folks hosting the webinar. And we'll try and go through the questions as we see them coming up. As you know, today you're going to be hearing from national data tool experts and two of our New Jersey grantees, so we're excited to have them be joining us. So if you have any questions for me or for them, please add those into the question box. If you run into any technical difficulties during the presentation, you can contact support by scrolling down to the bottom of your screen and clicking on Chat with Us. And you can connect with technical support that way. So if something's going on with the audio or your slides aren't advancing. You can use the dial-in information at the bottom left-hand corner of the screen to listen to the audio from a landline or a cell phone if you're listening through your computer right now and it's hard for you to hear. And for those who are participating just by phone and can't see the slides, we are recording the webinar and we will have a recording available at a later date. And finally, as the last bit of housekeeping, for more information on how the Robert Wood Johnson Foundation supports efforts to provide community leaders and residents with good local health data, as well as data about the drivers for health in the state of New Jersey and at the county and city level, and even more micro than that in some instances in New Jersey, please visit RWJF.org, www.rwjf.org. And also feel free to visit www.njhi.org to learn a little bit more about some of our grant-making efforts through New Jersey Health Initiative. So, with all of that behind me, I'm excited to introduce today's webinar host. We are joined by 4 people who collect, make sense of, and put data into action in a variety of different ways that inspire community change. Shoshanna Levine is the Program Director for the City Health Dashboard Initiative, which is housed at the Department of Population Health at the NYU School of Medicine. City Health Dashboard, which is a program near and dear to my heart, brings city-level information about health and its many determinants for the 500 largest cities in the United States. And as you can imagine, New Jersey has some fairly populous cities, so we are well represented in that data set. Following Shoshanna, you'll meet Sarah Treuhaft, who is a Managing Director at PolicyLink. And Sarah oversees PolicyLink's equitable economy work that advances policy solutions for racial and economic equity, provides leaders with relevant and actionable data, and uses that data along with other insights to really build a new narrative around why equity is so important. She also leads, and why she's on this call, the PolicyLink's National Equity Atlas Research Partnership, which is a partnership with the USC Program for Environmental and Regional Equity. Sarah has authored numerous reports on the issues of racial and economic inclusion, equitable development. She's written for the New York Times, Shelter Force, and Yes Magazine. We're excited for her to be with us today. You'll meet Greg Paulson, who's Executive Director of the Trenton Health Team, which is a community health improvement collaborative serving, unsurprisingly, Trenton, New Jersey. Trenton Health Team uses a data-driven approach. They work really intensely with different community groups to assess healthcare needs, help residents learn how to understand what the priorities are, and to advocate for them and care for themselves. And we'll also be hearing from Connelly, who's the Executive Director of the North Jersey Health Collaborative, which is a partnership of over 100 organizations working cross-sectorally to build capacity and improve community health in Morris, Passaic, Sussex, Warren, and Union counties. So, as you know, because you've registered to spend an hour of your time with us today, data can be a very powerful tool to help everyone in a community better understand their starting points when it comes to health, and provide a clear picture of what the challenges, opportunities, and what their path forward looks like when it comes to creating the kind of community or advancing progress toward the kind of community that folks want to live in. We know that data can be a really important rallying point. It can be, we've seen it at RWJ be a really great focusing tool to come up with a common platform. And we know that it can help residents, community leaders, policymakers, and advocates come together and set common goals for improvement and come together around common plans to drive change. By analyzing data, we can also tell stories about communities. And the more micro you can get with the data, the more compelling and interesting those stories can become. Often we see analyses that are done at either the county level tell one story, right? Then you can dig deeper. You can tell another story about how opportunities are not evenly distributed within a particular place. And in some cases, you can get down to the neighborhood level and say, you know, even though I live in Hudson County looks really great on this measure. We're actually seeing that when you look at the cities within Hudson County, the story is not the same. And when you dig into these particular neighborhoods and these particular cities within the county, maybe we ought to be focusing our efforts there. So that storytelling ability and the ability to pinpoint can be very compelling. So Robert Wood Johnson Foundation supports multiple efforts because of that to provide community leaders and residents with local health data. And again, we're going to be talking today with folks who represent different efforts associated with that work. But before we dive into that discussion and before I turn it over to our panelists, and I promise I'll stop talking soon, I want to just take a minute to do a quick poll of our audience because we'd like to understand who's on the phone and what data resources are already on your radar. So the question I'd love for you to answer just in the chat box, or not in the chat box, in the poll, is what resources are you currently using to inform the work being done in your community? All right, this is exciting. Seeing lots of county health rankings. I'm excited to tell some of our program staff here about that. Oh, wow, okay, we've got about a dozen folks who are using the City Health Dashboard. That's great to see. Folks using PolicyMap. For the folks selecting other, okay, healthierjc.com. That's great. Local data from police, EMS, hospitals. That's excellent to hear about. I might even send a little follow-up note to you to learn a little bit more about that. So that's great. Thanks so much. Stop this poll. Great. And I'm also curious to know what folks are using. This data for. That's poll number 2. All right. Setting priorities, uncovering gaps, targeting services. Yeah, runs the gamut. Okay, that is incredibly helpful, and I think illustrative, again, of the many potential uses for good and actionable information at many different levels within a community. So thank you so much for that. Now I want to turn it over, without further ado, to Shoshanna. Can you start by telling us a little bit more about the City Health Dashboard and how this tool can help communities advance their health initiatives?
Sure. Thank you so much Andrea. I'm very excited to be here today. So we all want our families and our communities to have fair and equal opportunities to be as healthy as they can be. And we also know that more and more Americans are moving to cities and smaller urban areas across the U.S. And until recently, very few measures have been available for cities to assess health, the factors that shape it, and the drivers of health equity analyzed down to the boundaries of their cities. And that's where the City Health Dashboard comes in. Our goal with the dashboard is to provide city leaders with an array of regularly refreshed data to support health-related decision-making. And when we drill down into the data into the city and community levels, we're calling attention to the things that aren't traditionally on our radar when we think about health. After all, we know that much change happens at these levels, and we really can't afford to ignore it. And so the City Health Dashboard launched in 2017 with 26 measures for 4 pilot cities: Flint, Michigan, Kansas City, Kansas, Providence, Rhode Island, and Waco, Texas. And this past May, the City Health Dashboard expanded to offer data on 37 measures for the 500 largest U.S. cities, which are cities with populations of about 66,000 or more. So we're not talking just the New Yorks and the San Franciscos and the Chicagos, but really down to some of these smaller towns as well. And this represents approximately a third of the U.S. population. And you can see on your screen a screenshot from the dashboard in Passaic, New Jersey. And there's 8 other cities for a total of 9 New Jersey cities included in the City Health Dashboard. Data comes from a variety of sources, and equipped with these data, local leaders have a clearer picture of the challenges facing their communities and how to address them. So you might be thinking, how does the City Health Dashboard help advance work being done in communities? For starters, it establishes an easy-to-use, one-stop resource for anyone to compare and contrast national data sets on things like clinical care, health behaviors, physical environment, health outcomes, and social and economic factors. And again, we're thinking here of a really broad definition of what it means to be a healthy community. So we have things in there like the insurance rate and the smoking rate, but we also have factors in there like the percent of children living in poverty, housing, diversity, and other factors like that. And the data is available for all measures at the city level and for about 2/3 of them at the neighborhood level as well. And we also have breakdowns by demographic features like race, ethnicity. And it informs priority setting and can guide a community coalition in where and what to focus on. You can find peer comparison cities and set your benchmarks for progress, and it also allows you to identify best practices and resources for driving change. So let me give you an example of how the City Health Dashboard has worked in New Jersey. So the city of Clifton is a large and diverse city, and it has been working on its community health assessment, and it found, similar to what you were saying, Andrea, that using county data didn't really reflect what was happening in the city. It's a really diverse city, both around race, ethnicity, and also socioeconomic status. People of varying socioeconomic status living in different neighborhoods across the city. And they're doing this community health assessment in order to become a nationally accredited health department. And so what they've done is that they've taken some data from the dashboard and they've pulled it out so they're able to present data for their city of Clifton, and then again looking even deeper at neighborhoods within Clifton, being able to highlight some of the disparities and some of the areas of focus for them. So for example, they've looked at insurance status, and they've been able to show that there's one neighborhood in Clifton that only has a 4% uninsured rate, which is fantastic, but there's another neighborhood that has a 35% uninsured rate. And so they're able to show those numbers, and they're able to show these maps that you can see here of the city and add to their report and really show, give that context to what is going on in the city. And they've collected some primary data too, and but because they've used the dashboard data for a lot of these baseline statistics that they need to include in the report, they've been able to focus that primary data collection on perceptions of residents, perceptions of leaders, being able to do some asset mapping, showing the services, showing the challenges that people are making, and have really been able to combine these data sources to put together a really robust report that will hopefully lead to them becoming an accredited health department. So we're really excited to be able to hear that example. And ultimately, a tool like the City Health Dashboard is beneficial for communities to look at and utilize in identifying best practices and resources for driving change. And moving forward, we really want to partner with cities and communities across the country, and of course in New Jersey, to work on making the dashboard as relevant and actionable as possible to the communities that the dashboard is available for. So make sure to get in touch with us. And thank you for having us, Andrea.
Sure, and for the folks who are just on the phone and can't see this in front of them, do you want to let people know your website URL?
That's a great point. You can go to cityhealthdashboard.com. And if you can see the slides, it's just under the title, and if you can't, again, it's just cityhealthdashboard.com.
Great. Thanks so much, Shoshanna. I hope that folks are going to have the opportunity to dive into the tool and get in touch with us, get in touch with Shoshanna to let us know if you have any questions. And now I'd like to turn it over to Sarah Treuhaft to speak about the National Equity Atlas. So Sarah, what's the primary goal of the Atlas, and what can local coalitions take back to their communities after using this tool?
Thank you so much, Andrea. It is great to be on with you all, since I saw through the survey that only 4 of you are using the National Equity Atlas. So I think that you have a resource to explore. So then the National Equity Atlas, our purpose is to provide community leaders and policymakers with deeply disaggregated data that allows them to track, measure, and make the case for inclusive growth in their communities. The National Equity Atlas is produced by a partnership with our university-based partners at the University of Southern California. It is a research institute led by Dr. Manuel Pastor, and we produced the National Equity Atlas to really meet this need in the world for more data that is disaggregated, especially by race, but also by gender, by ancestry, by economic status. And so we released the National Equity Atlas in 2014, and at that point it had data for the largest 150 metropolitan regions, all 50 states, and the US as a whole. In 2015, we added data. As Shoshanna was saying, people need local data, and we recognize that and focus on cities a lot in our work, so we added data for the 100 largest US cities. So that means that in the National Equity Atlas for New Jersey, you will find 2 cities, Jersey City and Newark, and then 4 metros, Trenton, and then the New York City, Philadelphia, and Allentown metros that New Jersey is a part of. And so our data, we have 34 measures, and they track our indicators framework, which looks at demographic change, how are your communities changing, racial and economic inclusion, and those racial and economic inclusion and equity metrics are broken into 3 categories. First, economic vitality. Can people participate in the economy and contribute to growth? Readiness. Are they ready to be the workforce of the future? Are they healthy? And then connectedness. Can they connect to the assets and resources in the region? And then we also have an indicator that shows the potential economic gains from racial equity. And this framework aligns with our approach to looking at equity and why it matters in communities. Because at that point, when we were launching the Atlas in 2014 and designing it before then, we were seeing all this data coming out from the US Census showing and highlighting how our communities are changing and how people of color are driving growth and change in the United States and in all of our communities. So for example, in New Jersey, you can find on the Atlas data on demographic change, and you see that now 43% of your residents are people of color. By 2030, it will be 52%. and then by 2050, it will be 63%. And you can then explore how are people of color broken down by group doing on a series of equity measures. Equity measures like housing burden, which you see here, broken down on the slide. If you can see it, broken down by race and gender, and you see that people of color tend to be renters. Some 60% of people of color in New Jersey are renters, but they also tend to be more housing burdened, and especially women of color headed households. And we have this sort of broken down data for many different indicators of racial and economic equity, in addition to health indicators like asthma, diabetes, et cetera. And in New Jersey, as I was saying, we have indicators that show the potential economic gains of closing those gaps, closing those racial wealth and income gaps. We find that in New Jersey, the economy could be $98 billion stronger every year if there were not racial gaps in income alone. So there's a tremendous gain to be made by working to close these gaps. And another crucial point about the Atlas is that in addition to providing this data, we want to provide people with solutions. So for every indicator, you find examples of what are the strategies that can work to close these gaps, and examples of how communities are implementing those solutions locally. So how are people using the Atlas? Since we released it in 2014, they're using it to understand the conditions in their communities and take action, and then to advance policy change. So a few examples for you here. We work in Pittsburgh with an equitable development collaborative, and they have two action teams, one focused on housing in neighborhoods, one focused on economic opportunity, and they are using the data in the Atlas to understand trends in their community and develop solutions, and then advocate for solutions to close the racial gaps on the indicators they're focusing on, including housing burden. In Fairfax, we worked with Fairfax to look comprehensively at the state of equity in the county, which is one of the wealthiest counties in the United States. But when you drill down and look at equity indicators, you see pockets of poverty that is racialized. And so they used the comprehensive analysis based on the Equity Atlas data to advance a One Fairfax equity policy in countywide and their school district. And that is driving an equitable development strategy and other policy approaches for the county. In California, advocates are using our data on $15 an hour to advance the $15 an hour minimum wage campaign, or they used it to advance that, and they actually won it. In New Orleans, housing advocates are using the data on rent burden to advance equitable housing policies. They used it to fight off a state ban on inclusionary zoning, and also to install a temporary ban on rentals like Airbnb that were destabilizing the housing market. And in Portland, the economic development institution there, the Economic Development Agency, is using the data on the economic gains from racial economic inclusion and equity to inform their equitable economic development and growth strategy. So those are just a few examples of how people are using this data, and I invite you to check it out and explore the New Jersey data that's in the Atlas. Thank you.
Fantastic, and I'm sure folks are going to have lots of questions for you. Before we transition, I want to also make sure that you have the same opportunity for the folks who are just listening. Could you remind them what your URL is? Or if we've muted you, I will share it with folks. It is nationalequityatlas.org. So far we've heard from two national data experts, Shoshanna and Sarah, on the data tool side, and we have other resources that we are happy to share with you, including several that you mentioned that you're using already, like the County Health Rankings. But now we want to transition to hear from two New Jersey communities who are really great examples of having turned data into action in our own backyard. First, let's start off with Greg Paulson, who's Executive Director of the Trenton Health Team. Greg, can you share with us how your organization is using data in your day-to-day work?
Thanks, Andrea. Sure, I'd be happy to. I mean, I think the first place to start is kind of how the organization came to be in the first place, which was the healthcare system in the greater Trenton community preparing to respond to a pending hospital closure. So the two acute care hospital systems, the Federally Qualified Health Center and the City Health Department, came together to say, let's work on these problems and solutions together. And some of the early data work, not surprisingly, was working on ER high utilizers, where the hospitals realized that they can better understand the frequency of visits and the needs and everything by coming into the same room and working on those things together. Part of our effort was to launch a regional health information exchange, which we did with our third vendor we ended up trying with in January of 2014. And that system now provides an integrated, holistic, longitudinal record for every person who receives care at one of our connected institutions, which is now more than 500,000 people who've come through the healthcare system in the greater Trenton region. And we have more than 850 clinical users who are in the system, usually at least a few times a week, accessing millions of records. So that's the first thing that we've done with the Health Information Exchange itself, is kind of sharing that holistic record of each patient so that you can avoid duplicate testing, you can have better understanding of records that come from a separate institution. But we've been fortunate with the particular system that we've implemented, because integral to that system is a population-level analytics system that lets us look at health trends across the community in real time. So not only can we look at diabetes prevalence, for example, or avoidable hospital visits or ER visits from diabetes, the system allows us to add variables and iterate questions in real time as we're looking at those reports. And I think that's been one of the most useful things that we've been working on here, is being able to go from a population level to a segment of interest and then to kind of slice and dice the data in that segment to identify related causes and ultimately get down to a list of the individual people who are potentially appropriate for a given intervention. So that work has really started at the clinical need, and it's driven the ability of our own organization and many of our partners throughout the greater Trenton community to better understand need, and I hope craft more successful grant applications and therefore grant-funded programs. Our Community Advisory Board, which started to help with our first Community Health Needs Assessment in 2012-2013, now has more than 100 organizations, and these are non-clinical organizations. There's the community-based organizations, faith-based educational institutions, all of them who have such a tremendous impact on the social determinants of health and therefore the overall health outcomes. And it's those partnerships that have really driven our recent data work as we have been trying to better understand the non-clinical social needs that are impacting the poor clinical outcomes and the high healthcare costs that we're seeing, and that ultimately impact the health of the population here. We're in the middle of implementing a social determinant referral tool that will allow for a standardized social determinant screen across the community and then tracked referrals to social service agencies. That tool is called NowPow, and because of the HIE backbone that we have across the community, we've been able to add on that tool as effectively a module within the HIE. So the HIE is becoming a technical backbone to better deploy additional data resources. We've also, we're fairly early, 3 to 6 months in work, integrating other social determinant type data or non-clinical data into the system. We have a project with our local school district where we're taking student attendance and performance records and bringing them into the HIE. Of course, the HIE works by being able to identify the same patient across different data sets. So for the HIE, bringing in student records and identifying which student record goes with what clinical data is a relatively simple concept technically, but it's going to allow us to address chronic absenteeism caused by health-related causes. For example, kids with asthma who are missing school for uncontrolled asthma, and even more exciting, go one step deeper and look at, well, why is their asthma uncontrolled? Most likely it's a home environment problem. Maybe there's mold in the home or excessive dust. So we're able to connect the resources in our community that are often disconnected from healthcare to be used in a more targeted way around non-clinical need that is driving poor clinical outcomes. We've also found that the perspective that we've developed, and it's a relatively small team in our organization that does this, but the perspective they've developed in working in multi-source, multi-sector data is different from what other institutions might have. For example, a data analytics person working in a hospital may spend quite a bit of time calculating measure performance, in which you really want to be very accurate and make sure you're not leaving any patient record behind. Where in our case, if we're looking at disease trends or other indicators across a population, population, we may only be operating in 70 or 80% completeness, but an 80% completeness of data may still give us the correct directional indicators such that we can get the answers we need and structure programs effectively, even with a little bit of a different approach or a different completeness standard than some others might use. So it's become a tool that we use internally quite a bit and that we make available to our partners, and we support our partners in using as we try to improve the overall health and well-being of the Greater Trenton community. I look forward to questions at the end, and I think I will hand it back over at this point. Thank you.
Right, that was fantastic. I'm so excited about the work that you're doing, so can't wait to get into the Q&A. But first, I'd like to round us off by turning it over to Connelly from the North Jersey Health Collaborative. So Catherine, you're the interim chair of NJCH's Committee on Data. Can you describe some of your data initiatives and what you're learning about North Jersey neighborhoods in the process?
Sure, thanks, Andrea. So as you mentioned earlier, the North Jersey Health Collaborative is a multi-sector partnership of more than 100 organizations working together across sectors. So it's healthcare, public health, social service organizations, and other community-based organizations that are coming together to work on improving community health in 5 counties in the northwest region of the state. And the collaborative was started in late 2013 in response to a need for a more coordinated effort and approach to creating healthier communities. So basically our core function is a shared process of community health needs assessment and then the development of health improvement plans in each county to address those targeted needs. So sharing data is central to our work, and it's made possible through our data platform, which is called NJ Health Matters. The NJH Health Matters website is the data and information and resource hub for the collaborative. And this platform is provided through our web vendor, Conduit Healthy Communities Institute, which provides more than 150 health-related data indicators that are pulled from various secondary data sources, including sources like, as we saw in the poll earlier, county health rankings, the CDC, census data, and so on, so that viewers can come to the site and they can compare New Jersey communities against national and state averages, county values, and in some instances, target goals for things like Healthy People 2020 or Healthy New Jersey, where that data is available. And depending on the data source, data is available at the county level. So if you're working in one of our 5 counties, you could certainly come and check out the data that we have on our site. The county level, municipality, the zip code, or sometimes it's even as specific as a census tract. And another really helpful tool that's on our website is called the Socio Needs Index. And this is a mapping resource that helps to identify communities that are most vulnerable in terms of poor outcomes associated with higher socioeconomic needs. So overall, this centralized data collection helps to align our partners around a common vision or view of what the needs are, and then we can have more strategic action in response to those identified needs. So the collaborative is currently in the process of conducting its 2nd shared community health needs assessment in each of the 5 counties that I mentioned earlier. But at this time that we did the assessment, our NJHC partners are aware that secondary data tells only part of the story. And so we wanted to go to the community, to the residents, to get more direct input for the people who live and work in our communities. So last year we launched our very first community voice survey. That was an online or print copy at some of our community events out in the community. Through our partners, we were able to collect more than 3,500 responses across our region. And this survey questionnaire was developed by our regional data committee, which again is made up of our various sectors and partner organizations. And it was based on the county health rankings and roadmaps framework, because we're also, as Greg had mentioned, very interested in some of the social determinants and how social needs are impacting health and health outcomes. So it's not surprising that we found across the region, all of our counties, that some of the issues that residents are highlighting as most challenging are affordable and comprehensive health insurance, including access to dental care, access to mental health and health care and substance use prevention and treatment, affordable housing, employment, and quality child and affordable child care. And so while this data is very useful to our partners for the work that we do through the collaborative, it's also really helpful to the individual organizations that participate, because they use this data also for their own strategic planning and things like grant applications. So bringing more local data to the collaborative and our partners continues to be one of our priorities. And then in addition to our 5 county committees, the collaborative also has 2 local neighborhood coalitions that have been made possible through grant initiatives. So up in Sussex County, we have a grant called Forward Franklin, which is a Build Health Challenge grant. And in Morris County, we have a grant called Morristown United for Healthy Living, which is a Building a Culture of Health grant through NJHI and Robert Wood Johnson Foundation. And these initiatives have helped us to take our work to the neighborhood and even the census tract level in Morristown. And in both of these initiatives, residents play a key role in the coalition. So we're really excited about a new strategy that we're using in Morristown. We've enlisted the help of 20 street captains in this census tract that is largely a Hispanic community with an immigrant population. About 30% of the households are linguistically isolated, so we know that we need to have bilingual street captains going out and talking with neighbors. And what they're really doing is going door to door and talking to their neighbors about what their needs are in terms of affordable housing and improving the community infrastructure there in that census tract of Morristown. And so what's really great about this is it's reaching out to those people who, for whatever reason, are not able to come to our monthly coalition meeting. Either it's not something they are ready to attend at this point, or they're working during that time, or whatever the issue is. It's making sure that we're getting to those people and letting them know about the work that's going on and finding out more about what their needs are. So we hope that this boots on the ground approach will really bring greater clarity and insight into the needs of the community and where to focus our efforts as the coalition's moving forward as part of our sustainability planning. So I hope this helps to illustrate how the NJHC partners use data to inform our work. It's certainly an evolving process, and we are constantly trying to assess and explore how we can have a greater impact. And then certainly data and engaging with community residents is critical to the process. So thanks, Andrea.
Thank you. Thank you. That was great. So now we're going to transition into the question and answer portion of the webinar. I've got a couple questions I want to throw out to the panelists, but for the folks on the line, if you want to just take a minute and share in the chat box what questions you have, either for the full group or if there's a particular person you'd like for me to direct the question to, please note that too. We're going to be watching that so that we can make sure that we're speaking to what is most of interest to you all. But first, since this was sort of sparked by both Catherine and Greg's comments, I'm curious. I mean, you both talked about different types of information that's being collected, and in some cases, personal health information, health data. And of course, we have to be mindful that this information, or even how it's collected, can sometimes be sensitive or confidential. So I'm curious if either of you or both of you could share a little bit about how you handle privacy concerns related to either how you're collecting data or how it's shared.
Sure, this is Greg. I'm happy to start. So the navigating the legal frameworks, and in fact, even within healthcare data, there are different federal and state frameworks. It's really a challenge. And one of the things that we've talked about quite a bit over the last 6 months or so was when we move beyond the original, treatment-based disclosures under HIPAA into more healthcare operations, where a lot of the community health level stuff falls, the treatment or the consent model changes slightly. So we've become much more careful at the beginning of projects to scope in enough legal time. We have a legal counsel who specializes in health data law, which has really been important for us, particularly as we're getting into areas where, frankly, the law or the combination of federal and state law don't yet directly address things. But I mentioned, for example, we're working with school data under a Princeton Area Community Foundation grant to address chronic absenteeism called All Kids Thrive. And there we actually have HIPAA and FERPA, the Educational Privacy Act, governing data. And what we've had to do is look at the workflow and say, what's the minimum amount of data we can disclose to the appropriate party in the school district to be able to use clinically sourced data that's covered by HIPAA and educational data covered by FERPA, and then at what point do we need to make sure we get parent consent before continuing any of the intervention. So it's a reality of the framework that we have to work in, and frankly, the legal barriers are really the challenge now. The technical barriers much less so. the last thing I'd say is, as we're moving forward, looking at this work over the next year, we really have the opportunity to maybe suggest some legislative changes here in New Jersey that would bring federal and state law more in line and address some of these other issues.
Yeah, and so I think I can just add to what Greg said, because I think he did a really great job of talking about the healthcare system side. But just to briefly, when we did our community voice survey out in the community, one of the things we did up front was to have a training session with any organization that was going to work with us in rolling out that survey. So providing guidelines about respecting confidentiality, just sort of really standardizing that process to make sure that people knew upfront going out that they had to be careful about how they disseminated those surveys, how the surveys were collected, and just making sure that we had some specific guidelines to share with them before we did that.
Gotcha. And I'm curious also, so Catherine, you talked about some of the work that you're doing with folks in the community as a way to gather information. I'm curious if you can share a little bit more about what you've seen as some of the more effective ways to engage people at the community level, either in data collection or in using health data. And when you answer that, we had a question come in through the Q&A box just asking for more information about what the Street Captain program is.
Yeah, sure. So, and the Street Captain program is really brand new for us, so I will have more information to share with that later on. But what we're doing, first off, we've recruited the Street Captains. They're working through our 2 community organizers that are part of the grant. We're holding a training session for the community organizers and the Street Captains in February on a Saturday to make sure that, to try to give them some more resources. We're finding that it's not so easy sometimes to go out and talk to your neighbors, so we want to make sure that they have some tools and resources to make sure that they know how to do that. We're also getting them a sort of a resource packet so that while they're out there talking to their neighbors, they can share programs and services with them that are available in the community. So one of our partners is Mars Habitat for Humanity. They had a home repair program that they were trying to distribute through the community members, and so we're trying to link them up with some of those services with the local farmers market, SNAP ads, things like that. So that is really an exchange of information that's going both ways. We're going to work on a data collection tool for the Street Captains. I don't have it yet, but we did do a needs assessment a few years ago in the census tract, and basically what we used was a small postcard with a couple of questions, and our community organizer really similarly went out and really just asked people for feedback. We did some focus groups. So that's the way we collected the data. And then we really share the data back through our monthly coalition meetings. So when the data is all collected and summarized, we'll put together summary reports and share it at those meetings. And in some cases, we post it on our those reports on our website too, if it's something that we can share, that it's de-identified and there's no issues with confidentiality, we'll share it on our website or through our newsletter.
Gotcha. And for others too, for Sarah, for Shoshanna, if you have any thoughts about especially effective ways you've seen in terms of working with folks at the community level to use data. Sarah, you had some really great examples of accomplishments that you were able to tie to use of the sites. But if you have any thoughts on especially effective or useful ways of helping to engage people with these types of data resources, it would be great if you could share them.
Yeah, I'm happy to answer that. I mean, I think that there are a variety of ways. I think since our focus is equity, it really matters who you are engaging, right? So it's like, who's already at the table, who are you working with to use data to inform the strategy? So I think that's always something to keep in mind, and that's something that we are mindful of whenever we get into community engagements. But I think that regardless of whether community is at the table at the beginning or you have the data and you go and engage people, there needs to be a process of helping people to understand what they're seeing, especially when you're looking at equity issues, racial disparities, economic disparities, and to really explore what is driving that gap that you see and what is behind it. So I think that having a process to do that. And then also we found that it is really important for the examples where we've seen people use data in a policy advocacy process, it takes some amount of working with the data producers and the data users to tell the right story and to get the data in the right shape and a simplified shape, usually a chart, one specific data point that really shows the issue and then you can be talked about with policymakers. So it really does help to have a process where you can refine data, put it in a fact sheet, some way of communicating the data and what is driving the issue, the equity issue with policymakers.
That's great. That's great.
And this is Shoshanna. I'll just kind of echo what Sarah said there. But we find that it's really having these visual components to the data. So, we've got the maps and a few graphs, and the Equity Atlas has some fantastic visuals as well, can really help distill down the message that you're trying to portray. And I would agree that trying to focus on one key number, if you're looking to kind of a non-data audience, can be really helpful in trying to focus the conversation, not overwhelm, and then trying to also tie that number, whatever your kind of key number is, to the experience of somebody in the community that's affected by whatever the statistic is. So we find that that data can be most impactful when it's tied to that personal story. We've also seen in some of the communities that are using the City Health Dashboard that the data in there, because we're providing data on health as well as some of those health drivers, has been really useful in bringing people to the table who don't think that they're working on health, but are actually really impacting the health of their communities. So in Waco, Texas, we had a collective impact initiative that had kind of a health arm, a health silo, and a financial security silo, and they were trying to bridge those gaps, and they really took these maps where they were looking at some of these health outcomes in specific neighborhoods and overlaid that with maps or showed them next to maps showing childhood poverty in those same neighborhoods, and really were able to kind of turn on the light for the people in that financial security group, saying, you don't think you're working on health, but really you're having a huge impact on the health of these communities.
That's great. That's great. And I think, we've found that to be true, or I found that to be true in our work with the county health rankings as well. It's usually much more impactful if you're able to tie that kind of quantitative information to personal stories, to people's individual experiences in their communities, and also to sort of distill out the role that lots of different people and lots of different sectors in a community play in making movement towards some of those numbers. So as you see, we're still in my Q&A. There are a couple of questions that I want to pull out from the chat box. One asked how the information on these platforms is disseminated. I can answer that briefly and also answer the question about whether any of these resources have information for the southernmost counties in the state of New Jersey. One of the tools that I'll be mentioning in a minute, countyhealthrankings.org, has information on every county in the state of New Jersey, including in the southern part of the state. City Health Dashboard and Equity Atlas have information pertinent to that area as well. Not necessarily as extensive with the City Health Dashboard, but please visit the websites and poke around. We have a question here that says, that's an interesting question. So this relates to privacy and consent here. So for the Trenton Health Team and others, oh, no, it's disappearing. I'm sorry, guys. Well, there's a couple of questions directed toward the Trenton Health Team, probably some of which might be better answered through direct outreach. But one of them that's sort of interesting is, do you look at citywide health data when you're looking at your HIE? Do you look at that data to help figure out what your care linkage network is going to look like, to develop sort of a formal set of providers you want to direct people to? And there's a related question about whether you use that data to make sure that you're steering people toward preventive services like screenings and immunizations.
Sure. So the interesting answer to that is it depends on the circumstances with which we have the data. So in terms of looking at overall disease states, and I think I saw that question come too, like late stage diagnosis for cancer, we've done a lot of that work through our Medicaid ACO. We're one of the 3 communities in the Medicaid ACO demonstration project in New Jersey, which means we get not only the clinical data from our connected partners, but we also get comprehensive Medicaid claims for every Medicaid beneficiary who lives in the geography. So for us, that's about 58,000 people. What that also means is that we're able to do that look across the population and have legal permission to do that. We're actually in the process of updating our business associates agreements with our hospitals and clinical partners to add this kind of community health assessment use case, because without that, standard treatment disclosures that allow us to share clinical information for treatment purposes don't cover us asking that question of kind of looking at those overall network things. But yes, we do. In fact, with cancer specifically, one of our hospital systems noticed much later stage diagnosis for their city-based hospital than the hospital based in a neighboring suburban community. And actually kind of related, we'd set up a navigation program with our community health workers to be able to attach to some of those patients and really understand not only why are they getting diagnosed later stage, but their treatment compliance was much lower. So, these are patients that even with relatively simple treatment plans weren't able to complete the treatment, and it was usually for a factor that someone was now experienced homelessness or had a house fire or had an income earner incarcerated, all those kinds of things that simply weren't disclosed to someone in the health community. So long answer, yes we do, but it depends on the specific permissions that are attached to each type of data.
Great. And there are some other questions that I think if folks, some that are very granular related to the Trenton Health Team, some questions that are more relevant to the North Jersey Health Collaborative. I think I'm going to go out on a limb and say that it's probably very easy to find these panelists and their contact information if you'd like to reach out for just to answer some of your more specific questions, because unfortunately we have to start wrapping up. So
is that information on the next slide? I think we had it somewhere.
Yes, we have everybody's website and additional data resources. I'm not sure if we have if we have folks' email addresses, but potentially. I do want to close us out though by pointing to a couple. Can you just go back one slide? We have a few other data resources that we didn't get to highlight on the webinar today. One of which I mentioned briefly, which is County Health Rankings. But these, in addition to resources like the City Health Dashboard and the Equity Atlas, give you just varying degrees of pictures about what your community's opportunities for health and health outcomes look like. So we've got 500 cities, which is CDC Behavioral Risk Factor Surveillance Service BRFIS data that's tabulated at the city level for the 500 largest cities in the country. And there's the City Health Dashboard pulls some of those data points and adds others. There are HOPE measures, which sort of give you a sense of the distance to go in closing various equity gaps. County Health Rankings gives you county-level health information for every county, almost every county in the United States, but certainly every county in New Jersey. Opportunity Atlas, which is a really interesting data tool that can give you a sense of another sort of look at community-level gaps. And then USA LEAP, which is our newest data set that we funded in conjunction with the CDC and the Public Health Information Statistics Group, that gives census tract, zip code census tract, small, very, very, very small area estimates of life expectancy at birth. Our goal was to have that for every census tract in the United States, every zip code in the United States, and we're getting close. So take a look at those resources if you want more detailed information. And then finally, I want to ask, I'll close this out with a poll. So we talked to you at the beginning about the data resources that you're currently using, and of course this is not an exhaustive list, and you shared many others that you're using. But I'm curious about whether anything might have changed and what data resources you think you might use moving forward. All right, seeing lots of movements here. Excellent. Well, I'm glad that the Equity Atlas has shot up quite a bit. I'm sure Sarah's very happy about that too. So thank you so much for joining us today. Thank you to our panelists, to the folks on the webinar, and there is contact information on the last slide. I was remiss in that earlier. And as I mentioned, this webinar is being recorded. We will share it with you at a later date. We look forward to it. You had lots of really great specific questions you had hoped to ask to Sarah, Shoshanna, Greg, and Catherine. Please feel free to shoot them a note. I'm sure they'd be thrilled to connect with you. But in the meantime, and once again, thank you so much for joining us. We're so excited to share some of the work that we're doing and to highlight some of the really great work happening in the state of New Jersey.